I'd like to now invite Gabor back to the stage to make a few closing comments.
Can you tell me how much time I got, Catherine? Do you know?
5 minutes? Okay, that'll be 10 minutes.
Okay, 5 minutes. We'll see what I can do. I'm just going to riff on the three speakers who told stories of success. Kelly's story about that patient who had Parkinson's, who had chronic pain, and substance abuse disorder. Now, if you look at the acronym substance abuse disorder, you get the word SAD. And I'm telling you one more time that Parkinson's, chronic pain, and substance use disorder all originate in childhood trauma. I can't prove that to you. I don't have the time to show you the physiology, but that's what happens. So it's a question then of how do we approach these people? And by the way, Parkinson's is about a dysfunction of dopamine. Addiction is about a dysfunction of dopamine. Your dopamine circuits develop early in childhood in relationship to the emotional environment. So there's a unity to it all. Now there's a question came up, which is that this client couldn't be housed in assisted living because he was a substance user. Now notice the contradiction. The medical definition of addiction, and which I don't agree with, by the way, is that it's largely an inherited brain disease. But if we accept the medical model as being accurate, then if somebody with substance use has got a disease, so why can't they be housed? What's the reason? What's the reason? I can tell you a personal memory of when I was working at the Portland Hotel in the downtown east side. We had a client who, prior to being admitted to our facility, had been in the emergency ward at St. Paul's Hospital 480 times in the previous year. When she moved into Portland, her mental health condition didn't change. She didn't stop being an addict. But over the next couple of years, those number of visits went down to something like 12 a year. The system was saved a whole lot of money and a whole lot of trouble simply because she was receiving compassionate care and she didn't feel she had to run to the emergency ward to get listened to get help. So where does this rule come from? Now, Catherine in the beginning talked about working within a broken system. This system is not broken. To say that it's broken is to assume that at some point it was whole. Never was. And again, it's not because of the lack of goodwill or expertise or intentions or commitment of anybody. It's because it's based on false assumptions that separate people's minds from their bodies and their life experience from their so-called pathology. In the next story, what struck me was Karen, the wife, who all of a sudden finds herself not just grieving her husband, which is of course a natural response, but lost in herself, like she starts withering away. What does that tell us? That tells us that she learned early in life that her only value was in the service of others. And that she had an existence only when she was helping and taking care of somebody else. Now, how did she learn that? Because as a child, that's the role she had to take on vis-a-vis her family of origin. All of a sudden, take away the object of her care, she doesn't know who she is. What the team did for her in Kathy's story, what the team fundamentally did for her was to validate her existence when she wasn't doing anything for anybody. Fundamentally, the message was, you're worth it just because you are. It doesn't depend on whether or not you're effective in taking care of somebody and being concerned with somebody else's welfare. So if we can deliver that message to people, that they matter just for who they are, just because they are, regardless of whether we like their behavior, regardless if they're fulfilling what we consider to be a useful function in life. Now, I'd like to tell you about that nurse who Marika mentioned, the same one to whom I said, how does this land for you? And really what I was asking her, she was talking about difficult clients at some point, and I think it was then I said to her, well, what's it like for you? And I heard either from her, or I forgot whether I heard through Marika or whether I heard from her directly. I think it was maybe through her directly, but I forget now because it was 6 years ago. The story was that she was quite angry with me after my talk, because I gave my usual talk on addiction and how we should approach, how I perceive we should approach the addicted person. And she thought I was blaming her for the way she was being. That's how she received it. Now, it wasn't my intention. I don't think that was my message either, but that's how she read it. But then I heard, I think from her, or maybe through Marika, that she started thinking about it. And she worked at one of the emergency wards in the Lower Mainland. I forget which one, Richmond or wherever it was. And there was a client who was a particularly difficult client who kept showing up, and everybody dreaded his appearances in the emergency ward because he always created such a ruckus, and he was always so unhappy and complaining so much and rude to everybody. The so-called difficult patient. I want you to pause for a moment and think about this designation, difficult patient. Who's actually experiencing the difficulty? You're the one experiencing the difficulty. The patient never gets to talk about the difficult system. We get to talk about the difficult patient. In any case, this nurse, that morning, something shifted in her, and she said to him, "Hey, how are you today?" And started relating to him in a different way. When he was discharged, all the other nurses came on and said, "Boy, was that guy different today?" And the nurse in question said, "No, he wasn't, I was." Now, you may think that what you heard today about compassion and presence and being with people and curiosity is just one more thing that you have to do. One more burden on you when you're already burdened enough. In fact, what you will be pleased to realize is that it actually lessens your burden. It makes your job a lot easier. The so-called difficult client becomes a lot less difficult if you just make a little shift in yourself. That's just how it actually happens to work. And I'm going to suggest something. If you took the word addict, and if you actually made it illegal to use the word addict about anybody, if every time you wanted to say the word addict, you had to say the following: so-and-so, you can't say he's an addict or she's an addict. You'd have to say, so-and-so is a human being who suffered so much in life that they're using substances to dull their pain. If you say that sentence every time you thought or talked about an addict, that alone would shift your attitude. And my mantra under addiction, if you remember nothing else from today, is not why the addiction. The first question is not why the addiction, which is only a response to the pain, but why the pain? And as soon as you ask that question, and if you take what Bashir said, what is your value here? If your value here is to help this person heal, then how you show up, and it's not a question even of, it's not a matter of, somebody said it's not a matter of what we do, it's how we do it. Well, that's true. But there's an even deeper truth. It's not a question of how we do it. It's a question of who we're being when we're doing it. Because people's brains are wired together. You may not have been taught this, but there's a man, a physician, researcher in LA, who's written a book called The Social Brain. And Dr. Dan Siegel, who's a prominent teacher and psychiatrist and researcher, he talks about interpersonal neurobiology, that our brains are actually wired together. And you know that because when you're with somebody who's calm and grounded and open-minded, your brain is functioning differently than you're with somebody who is judgmental and curt and impatient with you. You become a different person because our brains are wired together. It's interpersonal. So we actually have the capacity to change the other person's neurobiology simply by how we show up. And I'll end with one final comment. Marika was talking about, she's already made the point, I just want to expand on it, about self-care and compassion. And I agree with what you heard this morning about what they call compassion fatigue is often based on frustration. That's true. But there's another side to it as well. And I also agree with what you heard this morning, that nobody ever gets tired of being compassionate. Compassion does not cause fatigue. However, the compassion has to flow both ways. If it's only flowing from you to the other person, and Marika's friend fell into this category, the compassion was only going outwards, but it wasn't coming inwards. She was not looking after herself. She identified too much with the pain and suffering and needs of her clients. You can't keep that up. The problem is not that you're compassionate towards them. The compassion is that you're not looking after yourself. So I don't call it compassion fatigue. I call it a lack of compassion fatigue, in the sense that you're lacking the compassion for yourself. So to end this, Dave, from my perspective then, all this stuff that we said about compassion for others, you also have to apply it to yourself. And that's difficult to do, because there's one thing that healthcare providers tend to have in common. I don't say universally, but overwhelmingly, is we tend to be the kind of persons who are programmed by our childhoods to be caregivers. And it's easier for us, and it's more comfortable for us, to be looking after the needs of others than to looking at our own. So the compassion has to be both ways. And thanks very much.